I guess Dana, who normally introduced me, isn't here, so I'll just introduce myself. I'm Stephen Chessler. I'm with the Department of Medicine, Division of Endocrinology. Thank you for coming. Today I'm going to talk about the All of Us program after first talking about precision medicine in diabetes. I'm affiliated with the UCI Diabetes Center, and I'm also affiliated with the All of Us program, in addition to having a practice over in the Gottschalk building. So to begin with, I'll talk about what is precision medicine. And this is the All of Us program, which I'll talk about later, their definition. It's an approach for disease treatment and prevention that takes into account individual variability in lifestyle, environment, and biological makeup. In other words, it's an approach to medicine that takes a lot of data about you, the individual, and designs treatments based on you, so it's individualized medicine. Precision medicine gives clinicians tools to better understand the complex mechanisms underlying a person's health, disease, or condition, and to better predict which treatments will be most effective. Again, the basic premise is getting a lot of data about you as an individual and using that data to determine the optimal treatment for you. So not just asking what disease you have, but taking into account a lot more data. And it's a radical shift in how each of us can receive the best care possible based on our unique characteristics. So this is considered the future of medicine. We're trying to move in this direction to better target treatment, to be more effective in treatment, and to reduce side effects. Precision medicine is perhaps most advanced in cancer. The oncologists are ahead of us in adapting it, and it's been most dramatic there. In cancer, in oncology, it's a form of medicine that uses information about this is the NCI, National Cancer Institute's definition. It's very similar to the All of Us definition. It's a form of medicine that uses information about a person's genes, proteins, and environment to prevent, diagnose, and treat disease. Again, it's individualized medicine. And where it's been most dramatic in cancer, and we hope it will have as dramatic effects in other arenas of medicine as well, is in treating specific tumors, is in asking what what mutation is causing a tumor and targeting treatments to that mutation. So it's in cancer, it's identification of genetic alterations, in other words, mutations that cause the growth of tumors. And it's treatment with drugs that specifically are designed for that mutation, that treat that mutation, that inhibit the function of that mutation. And in oncology, because their drugs are so poisonous and have such devastating side effects, they're increasingly trying to use precision medicine to decide the optimal therapy for everyone's tumor based on the genetic sequence of that tumor. So there's been many dramatic examples in oncology. Here's, for example, is a patient who had a salivary gland tumor with many metastases. And then you take the tumor tissue, you sequence it, you determine what is the mutation causing that tumor growth, and then fortunately there's a drug that specifically counteracts that mutation, and you can see dramatic, so here's tumor and here the tumor's gone. And there's been many examples of very dramatic responses in cancer to precision medicine, to gene mutation specific treatments. Now, how about in diabetes? What I want to talk about in diabetes and underscore is the increasing complexity of the disease. It turns out there's more and more types of diabetes and more treatments. So this increases the need for precision medicine as we recognize increased differences in the type of diabetes people have, and we have more medicines to choose from. It's becoming increasingly important that we develop it for diabetes. Diabetes, this is an early definition. Even when this definition was devised, we realized it was a group of metabolic diseases, all having in common high blood sugars, resulting from defects in insulin action, insulin secretion, or both. So here already you can begin to see there's complexity, that different people have different disease mechanisms, perhaps requiring different therapies. And again, to emphasize, there's two underlying factors. In type 1 diabetes, insulin's production is too little due to an immune attack on the insulin-producing cells. In type 2 diabetes, there's both problems. There's, for different reasons, the cells that make insulin fail over time, And on top of that, for various reasons, the body doesn't respond well to insulin. Diabetes is a complex disease. And further added to complexity, now it's become, instead of causing, because we have insulin and other treatments, it's become a long-term disease. People can live long-term with it. It causes abnormalities in metabolism that result in what's currently is the main problem, the biggest effect on public health, the biggest effect on morbidity and mortality, and that's the end organ damage, including retinopathy, which will be discussed later. So diabetes causes retinopathy, kidney disease, nerve disease, heart and blood vessels. It's the #1 cause, for example, of individuals needing dialysis or individuals needing amputation. Again, diabetes, then this increases the complexity of the disease further. Not only are there different reasons to have high blood glucose, to have these metabolic derangements, but the metabolic derangements themselves cause different pathologies in different tissues. Because of the complexity, then we want to be able to understand what's causing diabetes in different people, what form they have, and to target it to individuals, appropriate treatment, and that's what precision medicine is. When I was in training, there was a very limited number of forms of diabetes recognized. Type 1, which we called juvenile diabetes back then, caused by autoimmune damage to the cells that make insulin. Type 2 diabetes, still the most common kind, caused by insulin resistance, most often due to obesity and also failure of the cells that make insulin. I'm going to talk about what are called monogenic forms, forms caused by one gene mutation later on. MODY is one of those. Now, larger studies have seen that if you take individuals' diabetes and classify them according to, for example, the age at onset, the level of obesity or the BMI, this is how much insulin they can make. That's the C-peptide as a marker of insulin production. Or autoantibodies, immune markers they might have in their blood, and we take all this data and we cluster them. We see that there's commonalities in these clusters in terms of susceptibility to eye damage or kidney damage, or in terms of what medicines, therapies best treat them. For example, people with a subcategory called severe immune deficiency diabetes perhaps should be screened for retinopathy more often. They have a higher risk and perhaps should be treated with insulin earlier on. This is an example, but we don't do this. We don't have this classification. The goal of precision medicine is to take this type of classification beyond research to make it more precise and to develop and to be able to better target therapies to the individual based on their specific characteristics. When I was in training, there was basically 3 treatments for diabetes. Various types of insulin, short-acting, long-acting, sulfonylureas, medicines you may have heard of, glyburide, glipizide, and so on, and metformin, still most commonly our first choice in type 2 diabetes, metformin. But look what's happened since 1995 or so. There's been a blossoming of new therapies. Diabetes has become a lot more fun to treat because there's a lot more therapies, a lot more options. So the top line here includes those options. So here's insulin, which we had before, metformin, which we had before. But there's new agents have come along. Importantly, new agents like the GLP-1 agonists, which are advertised, you may have heard advertised as Trulicity or Victoza, or the SGLT2 inhibitors, which you may have seen advertised, called Jardiance, and other such drugs. Another twist is some of these new medications, unlike the older ones, not only help your diabetes, help glucose control, but also reduce the risk of certain types of organ damage, cardiovascular disease or kidney disease. So diabetes therapy is becoming more complex. So ultimately the goal then is to take individuals, each who have individual characteristics, might have certain genes in common or age, take them and use data such as data regarding how much insulin they can make, or markers in their blood, various kinds of markers in their blood, say inflammatory markers or chemical markers. Metabolomics is a fancy word for looking for chemical markers in the blood. Or looking at their gut, this is a hot topic these days, what kind of organisms are growing in the gut, and their lifestyle, breaking them down and using that to break them into specific clusters that are best treated with specific therapies. Right now, the way we treat is it's much more of a kind of a fuzzy, more almost an art as much as a science. We look at, well, this patient might be, somewhat on this, towards this end in terms of obesity, but maybe towards this end in terms of how much insulin they make, and maybe here about how much, whether they have antibody markers, and then we guess, we do our best guess, and we work with the patients to devise the optimal treatment. This is the current American Diabetes Association guidelines for treatment. This is the state of the art right now. We don't have precision medicine. What we have is different pathways we can choose from worth the patient. This is very different than the cancer example I showed you, where we took the mutation and we used that to decide what the therapy was. Here we have a lot of options. Well, maybe we can take into account that they have heart disease, but there's a limited amount of data that goes into it and a lot of choices. Now, I mentioned before monogenic or single gene disorders causing diabetes. That's a small percent of diabetes, but it's an example where precision medicine works in diabetes. So, there are different forms of diabetes. Again, these are rare, but that are caused by single gene disorders. For example, these are examples of some of these single gene disorders. And what's important is if you identify these patients, if you identify a patient with diabetes with a mutation caused by mutation in the gene for glucokinase, for example, these patients you can stop treatment. They don't need treatment. They do fine over time. They might have slightly high glucose sugar levels in their blood, but they do fine. There's examples of patients with this mutation having to suffer insulin treatment for years and years, and they're found to have this treatment, and it turns out, lo and behold, they can be treated optimally with a much easier to use. Not only is this drug easier to use because it's oral, but furthermore, it's more efficacious. So this is an example of monogenic, of precision medicine in diabetes, of those monogenic disorders. So Lily Jaffe was diagnosed with type 1 diabetes and started at 1 month of age on insulin, 1 month of age. And think of how hard insulin to use. It's multiple injections that can cause hypoglycemia. Her father, when she was age 6, attended a meeting where he heard a speaker discuss that many babies diagnosed neonates at such a young age often have one of these single gene disorders causing their diabetes. He had her tested, and this is her at age 6, shortly before she stopped using the insulin pump forever. After that, she was put on an oral medication, much easier to use, and subsequently, as you can see here, become an advocate for testing for these disorders. So this is precision medicine, taking the gene, taking data about the person and optimizing treatment, in her case, sulfonylureas. This is the Moynihan family in Toronto. Michaela was started on insulin as a baby. She's 4 in this picture. Her father, Scott, was diagnosed with type 1 as a baby and put on insulin. And Tom, the grandfather, was put on insulin at age 21. A smart physician saw, well, look at this family inheritance. Maybe I should check for a single gene disorder. So genetic testing led to a single gene disorder called MODY. There's several different forms of MODY. These are all single gene disorders that cause diabetes. And they were able, as a result, they were able to come off insulin on a much easier to use oral medication. And Tom, the grandfather, said, quoted in the article, to have this gift handed to you at 65 years old is just absolutely phenomenal. And to be able to, look at life so differently going forward and knowing, you aren't going to run into side effects of diabetes, which is really a big worry for every diabetic. Obviously for Scott and Michaela, well, they've been given a clean slate for their life, and that's pretty important. So again, having precision medicine allows this type of outcome, optimizing treatment, minimizing side effects. So this is where we are with monogenic diabetes, like we just discussed, MODY. We can precisely target treatments. And here we are with type 2, the most common type of diabetes, and we're not at that point yet, as I tried to make, as I described in the prior slides. So this is the goal, to develop precision medicine for diabetes. So we can take control patients, we can take patients with diabetes and collect all kinds of data on them, collect data about their genomes, which means the sequences of their DNA, data about the chemicals in their blood, metabolomics, data about the proteins they make, about their lifestyle, and then use that to classify them and determine what kind of treatment is optimal for them. And that leads us to the All of Us program, which I'm involved in. And the goal is to develop precision medicine for all diseases, not just diabetes. It's to improve our ability to prevent and treat diseases based on individual differences. In other words, it's to develop precision medicine. The All of Us program is part of the Precision Medicine Initiative announced in previous President Obama's State of the Union in 2015, and is to enable a new era of medicine through research, technology, and policies that empower patients, researchers, and providers to work together to the development of individualized care. Individualized care is synonymous with precision medicine. The Precision Medicine Initiative resulted in the passage of the 21st Century Cures Act, and $1.5 billion over 10 years was allocated to the All of Us program and other programs. Subsequently, the amount has been increased. So there's a big national commitment at the federal level to developing precision medicine through this program. The All of Us program is the center of the Precision Medicine Initiative, and the goal is to enroll 1 million or more individuals in the program to reflect the diversity of the U.S. Anyone over 18 is, no matter what your background or condition or age, is welcome to join. And once you join, participants are asked to be more than just subjects, but to actively participate. Over time, you'll get surveys, or you might be asked to wear a Fitbit, or to have your, and everyone is asked to make their electronic medical records available in a private, privacy-protected fashion. Initially, when people sign up, I signed up, for example, you're asked to give permission to access your health record. You fill out some surveys. Your weight and blood pressure are taken. Blood and urine are taken. If you can't donate blood, then saliva is taken. And eventually, people who participate will be asked to participate to answer further surveys, or to provide, perhaps, wear a Fitbit, or provide other such data. The goal is to develop this large database to enable the development, researchers to have access to, and enable the development of the type of precision medicine I described earlier. So the goals are, it's a new model of research. Again, it's over time, and the 1 million people are asked to be actively participate. It's to be a very rich source of data, and it's going to be available for free to qualified researchers worldwide, to help accelerate advances in precision medicine and lead to increased knowledge, leading to precision medicine for diabetes and other diseases. People who participate, including, we ask our patients here to participate, anyone can participate. Everyone's entire genome, every base pair in your genome, in your chromosomes, will be sequenced. And ultimately, information about you will be provided back, maybe ancestral if you want it, maybe susceptible to diseases if you want such information. And it's a chance to participate in this large national effort to develop in precision medicine. And let me just finish by saying that UCI, under the leadership of Hoda Anton Culver, is actually we're proud to be, we're one of the leading institutions in the nation in implementing this in terms of success of recruitment. And if you're interested, you can go to this website or call this number and to participate. And ultimately, like I said, the goal is the type of precision medicine that helped Lily Jaffe and the Canadian family that I talked about earlier. Thank you. If he can give informed, you have to be over 18, and if you can give informed consent in either Spanish or English, if you can read the risks and benefits of the program and sign off on it, then anyone can join, including your father. You get $25 you get $25 as gratitude for your time, as thanks for your time. That's a good question. Yes, right. It's interesting to see how the government works from the inside. I don't know. They're getting up and going with it. It's getting up and running. Last I heard, they're piloting the sequencing, but I don't know when they're going to. We're talking about 1 million people. Everyone has 6 billion base pairs in their genome. But the sequencing has gotten enormously fast, and it's getting faster and less expensive, but I don't know the time course. Yeah, well, ultimately the data will be made available to qualified researchers, and your name wouldn't be associated with it. In terms of who's going to look at your data, Vanderbilt, there's a data center at Vanderbilt. So they're going to take this vast quantity of information, and they're going to be processing it and looking for mutations. And then ultimately, genetic counselors have to be hired, because if we're going to be informing people they have diseases, they have to be asked if they want it. But so ultimately, the money is allocated, the sequencing has started, but I don't know the time course, but Vanderbilt is where the data will be kept, and the program is the one that will be giving you feedback on your information, giving you feedback on your genome.
The program meaning Vanderbilt?
No, the All of Us program, Vanderbilt is the data center, yeah. That's the challenge of the program, but by virtue of giving them permission to access your record, hopefully there's increasing communication. The goal of the electronic medical records is for there to be interchangeable information and be able to talk to each other. So ultimately, hopefully, the ability to access your records over time will come. Well, going forward, there's not a plan to access past records. So current records going forward is the plan. No. You have to ask, qualified research have to ask permission to get access to the data. And then the data is provided in an anonymized fashion, right? So your name won't be attached. Just like that's the way a lot of clinical studies work. Is there's blood samples, but the researchers will get 100 blood samples and they'll know the characteristics, but they won't know the name of the individual patient. There's a lot of attention obviously it's a huge issue, and there's a lot of attention being paid to that. So they have some very good security people. Then unfortunately that happens sometimes, so you're not fully enrolled until you either give a blood or saliva sample. So that means I guess you should call the number, or you probably didn't get your $25 gift certificate either then. Yeah, so you know you've gone through the whole process when you get your $25 gift certificate. Yeah, so you should probably contact them, and then they should get your urine and blood and your measurements to be fully enrolled. Well, yeah, so the Vanderbilt, your name will be attached to the data at Vanderbilt. When they distribute the data, it'll be anonymous, but your name will still be attached to it at Vanderbilt. Just at Vanderbilt, there'll be security, as good as can be to prevent people from accessing it. But when it's distributed to researchers, it'll be distributed in large chunks of group data. So I have confidence. I mean, I'm participating. I have confidence in it. But if you're concerned, you can always call and ask or read about it. But just it's probably safer than your credit card information or all your other data. Yeah, I mean, you should call them and see. I mean, go through the enrollment process. The consent form will go through all that. And I don't know if the consent form specifies whether they have access to past records or not. It's been a while since I read the consent form. Like I said, I consented myself. If you're concerned about them having access to your past records, then you wouldn't want to sign off on that aspect of the consent. You could still enroll if you don't, and give the blood and everything, even if you don't give consent to give access to your medical records. Potentially, I mean, it's to target therapies. So if it's found that someone with a certain gene or a certain background or lifestyle responds best to some certain integrative medicine therapy, then yes, it would be applicable to that as well. It's basically whatever therapy is optimal based on your genes, lifestyle, background, genetics, and so on. So that would be included, sure. Yeah, it's in it. I think it's just completing its first year. I think they have 200,000. Don't quote me on this. 150,000 participants. So it'll take. It's a 10-year program, and in terms of ramping up so in terms of they have the money and I go to these meetings, and so it's preliminary, but everything's getting ramped up. I mean, I haven't gotten my sequencing back yet either. It will happen though. I mean, it's an enormous effort.